friends, in today's presentation, I will be talking about some simple steps by which you can easily reduce supracondylar fractures of humerus and pin them appropriately to provide a stable construct, especially with the rotational correction. Usually, whenever we reduce supracondylar fracture, there is some component of residual rotation still visible. How can we correct it? So we'll be seeing all these points which can be handled easily in supracondylar fractures. So first of all, you have to reduce the fracture by giving manual traction. Usually, if you see here, there is some rotation of the distal fragment, and when we give traction, there is somewhat better alignment. You see, some space is visible here. That means some translation is still there, but rotation appears to be more or less okay here. So this is the AP view, and what we do, we keep the arm on an arm support and take an AP view as we normally do. After this step, you have to place a K-wire over this region so that you can know what is the desired trajectory. Sometimes the fracture is quite high, that means it is on the topmost part of the supracondylar region, then your trajectory has to be more vertical. But when the fracture is low, like it is here, you can go for an oblique trajectory, which is going to get good purchase on the opposite side cortex. So that should not be an issue. So this is a wire placed over the skin to know the direction of your trajectory. Now what you need to do, you have to palpate the lateral epicondylar area. The posterolateral part of the lateral condyle is quite prominent. If you try to palpate your lateral condyle as well, you will be able to palpate the bony flare of the lateral condyle, which is mainly on the posterolateral part. Now anteriorly we have the capillum, so we need not to span the capillum. We want to avoid going through the capillum because that is mostly cartilageous and also the area where growth has to happen. So we have to go a bit more posterolateral. So you have to place a wire on the posterolateral side, insert it just short of the fracture, because we are yet to see the lateral view. So you have to insert the wire just short of fracture like this we have done here, and then check the lateral view. Now common problem that we do in checking the lateral view is that we keep the C-arm like this and try to rotate the arm to get a lateral view, but that has to be avoided, because what you are actually doing, you are actually mal-aligning the AP view as well by doing this maneuver. So you have to get a C-arm like this. That means your arm has to be over the table. Do not rotate the arm at all at this point, and then check the C-arm. So your wire is in the posterolateral part, that has been confirmed, but this fragment is still rotated. So what you can do here, you can flex the arm and you have to push manually oblique part here and try to hyperflex the elbow. That will lock the reduction in this particular position, and then you will be able to align the wire towards any of the opposite cortex. Like here, the wire is going to enter inside the canal and going to hit the opposite cortex at some point. So this is the orientation of the wire if we see from the lateral side, and this is the orientation of the wire if we see from the axial side, that means along the axis of the arm. And this is the way we are getting the lateral view. So here we have spanned the wire on the opposite cortex. Now here you see there is minor mismatch in the cortex here, but do not bother about that at all at this point, because the wire that you have inserted here is only going to act like a hinge. Your fracture can still rotate, and we are going to correct the rotation with this wire acting as a hinge. So in the next step, you see what we have done. We try to get another view in the same position, and you see there is some overriding of the cortex here. That means some residual rotation is still remaining. Residents often remove this wire and try to revise the fixation, but that is not required at all. Minor rotation like this can be corrected while keeping this wire in situ. At this point, if we try to rotate it internally, the rotational mismatch is going to be more. You see the cortical overriding or cortical mismatch is more prominent when we do, but when we do external rotation, see what happens. With external rotation, the rotation is going to be corrected. Why this is happening? Because the deformation happening in most supracondylar fractures is the internal rotation deformation. This fragment tends to go into internal rotation because of the proximal pull of the muscles, and commonly there is varus deformation and internal rotation of the distal fragment. So what we are doing by external rotation, we are actually going to correct that malrotation. The axial component, that means the valgus varus part, has been addressed when we gave the inline traction, and this wire is going to prevent that kind of malalignment, because we already have one wire in C2 that is going to prevent the malalignment in coronal plane. So this is the position of arm when we do external rotation. the medial epicondyle comes more anteriorly. And if you try to rotate it further externally, the rotation of the distal fragment will not change. Why this will not change? Because the fragments are getting locked after one particular external rotation position. Now when you have done external rotation, you can simply take a conventional lateral view. That means you can place the C-arm directly in the AP position as we normally do, because the rotational component has been addressed by doing the external rotation. Now at this point, when the rotation component has mostly been addressed, you have to place another wire from the medial side. So the best biomechanical construct for supracondylar fracture will be two wires entering from the opposite side. That means one from the lateral condyle, one from the medial condyle. So I will recommend to add a wire from the medial side always, because that will definitely prevent the rotational component. Because often when you have placed 2 or even 3 K wires from the lateral side alone, then after you are getting the X-ray, still there is some loss of reduction, because the hinge that is on the medial side has not been addressed. The fragment can still rotate slightly with extra stress. So whenever the radiographer is positioning the arm in internal rotation, the stress is actually transmitted on the medial side, and that results in the rotational component that we see in the post-op X-rays. So the medial wire has to be placed while keeping the elbow in slight extension. That means you need not to hyperflex the elbow at this point, because that will actually make the ulnar nerve taut, and taut ulnar nerve will be prone to injury by the wire. So the safe thing is to slightly extend the elbow, and when you do that extension, you may experience some opening here, and you may also experience some loss of reduction as well, mostly on the anterior side. But that should not be an issue, because this maneuver is required only for locating the medial epicondyle. Once medial epicondyle has been located, you just place a wire over that bony prominence, or you can simply insert the wire a millimeter, 1 or 2 millimeter inside the medial epicondyle. Once that is done, you start doing your maneuver again. That means you flex the elbow and you try to externally rotate the elbow so that the anterior continuity and the posterior continuity is mostly restored. So this is the conventional AP view we are getting, but the arm is rotated externally, so we are getting a good lateral view as well. And external rotation is actually helping in the reduction. So this is the position of the elbow at this current position, and we already have entered the wire in the epicondyle. Now we'll be able to insert the wire inside towards the opposite cortex. So this wire has been inserted towards the opposite cortex. So this fracture was slightly comminuted. There was some green stick component. Still we are able to get a reasonable alignment in lateral view. That means there's minimal rotational mismatch, if at all. So we check the AP view again. So the AP view appears to be satisfactory. You see the cortical ridge, the medial and lateral ridges have been perfectly restored. And if we want to check whether there is some rotational mismatch still persisting or not, what we can do, we can take the oblique views. In oblique views, we should be able to locate this round shadow of the olecranon fossa, and also the ridges should appear symmetrical in any view that we are getting. Commonly when the residents get the X-ray and they see slight mismatch here, they tell that the X-ray is not true lateral, and they try to show the C-arm images which show good alignment. But why the reduction is appearing bad in the oblique view? Because the rotation component is still persisting. So here two wires, one from the lateral side and one from the medial side, are actually going through the strong bone component. They are going through the ridges, or you can say medial and lateral column, and that's why they are more stable than the wires placed on the lateral side alone. So always place two wires, one from the lateral side, one from the medial side. After that, you have to assess whether the fracture was comminuted, whether the bone profile is large or not. If you think that the bone profile is large and you want to supplement fixation with extra K wire, you can simply add one more positional K wire from the lateral side or even from the medial side, because now you have already exposed the medial epicondyle, and further extension or flexion of the elbow will not hinder your reduction, because you have already placed two K wires from each column, that means medial side and lateral side. And after that, the protocol is simple. You have to immobilize for around 2-3 weeks. Then you have to start gentle movements. And in unstable fractures in older patients, we remove the wires at around 6 weeks. In younger patients, like less than 5 years of age, we remove the wires at 3 to 4 weeks. and then we start the mobilization. So I hope this short video regarding the basic steps and tips for reduction in supracondylar fractures will be helpful for you in your surgical planning. If you have any queries regarding this, you can just ask those in comments. Thank you.